Okay. I hope you can hear and see the PPT also.
Yeah, yeah.
Okay. Okay. Continuing. Okay. So thalidomide is effective in nerve abscess, type 1 lepra reaction, type 2 lepra reaction, and both type 1 and type 2 lepra reaction. And the answer will be type 2 lepra reaction. So type 1 lepra reaction is reversible reaction, and type 2 is ENL or erythema nodosum leprosum. It is also called erythema nodosum leprosum, type 2 lepra reaction. So type 1 lepra reaction is delayed hypersensitivity reaction. That is type 4 hypersensitivity reaction, delayed one. And type 2 lepra reaction is type 3 hypersensitivity, or it is also called Jarisch-Herxheimer reaction. Type 1 lepra reaction is found in tuberculoid type of leprosy, tubercular type, and type 2 is found in lepromatous leprosy, LL type. This is TT and this is LL. Thalidomide has no role in type 1 reaction, while thalidomide is the most effective drug in type 2 lepra reaction. DOC is corticosteroid. So DOC is corticosteroid, and also in both the in type 1 and type 2, DOC is corticosteroid, and thalidomide has role in type 2 reaction, but in type 1 thalidomide has no role. Now thalidomide is absolutely contraindicated in women of childbearing age, because there is a chance, it has been found that thalidomide is highly associated with phocomelia or seal limb deformity. Seal limb deformity. Okay, that means the limb of the fetus will not get separated. Okay, phocomelia. That is why thalidomide is not given to the women of childbearing age, in childbearing ages. And both in type 1 type 2 we go for, as a treatment purpose, we go for corticosteroids. Okay, next question. Lichen planus is associated with Koilonychia, tinea versicolor, psoriasis, pterygium of Nell. So lichen planus is associated with pterygium of Nell. Pterygium of Nell. So this is a typical lichen planus. This is a typical lichen planus picture. And pterygium of Nell specifically is this. Pterygium of Nell is this. Okay, so what is, first of all, we will see what is pterygium of Nell. When the proximal nail folds, when the proximal nail fold overgrows and invades the nail bed. Pterygium, we know pterygium, this word, this term we also get in ophthalmology. Invasion of something into somewhere. So here in this case, proximal nail fold invades the nail bed. Proximal nail fold invades nail bed. There arises a nail disorder and is termed as pterygium of nail. This refers to the unexpected penetration of nail fold into nail bed. Origin of this disorder is the matrix of the nail. So pterygium of nail, in this condition, proximal nail fold invades nail bed. Now lichen planus is the disease of skin and mucous membrane that resembles lichen, and it's an autoimmune disorder. And lichen planus may be categorized as affecting mucosal or cutaneous surface. Affecting mucosal or cutaneous surfaces. Cutaneous forms are those affecting the skin, scalp, and nails. And pterygium of nail is characteristically seen in lichen planus. And Koilonychia is found in iron deficiency anemia. It's completely different thing, not megaloblastic, in iron deficiency anemia. And the nail becomes like spoon shaped. You can see this is the nail, it becomes like spoon shaped. Okay, like spoon shaped. Okay, so pattern of nail involvement in different condition, like in iron deficiency anemia, we just now saw that koilonychia occurs. In arsenic poisoning, meseline, lichen planus, pterygium of nail, onychia, onychorexis, pitting of nail also occurs in lichen planus. And in psoriasis, pitting of nail, that is thimble nail, oil drop nail, onycholysis. In onycholysis, detachment of nail plate occurs. So just to remember the each of these pattern of nail involvement in different conditions. Meseline is found in arsenic poisoning. In lichen planus, pterygium of nail, onychia, onychia, onychorexis, pitting. And pitting of nail is found both in lichen planus and psoriasis. And oil drop nails are also found in psoriasis. Detachment of nail plate is found in onycholysis. So these are some of the pattern of nail involvement in different conditions. So this is about lichen planus. Okay, lichen planus diagnosis and management. First of all, diagnosis of lichen planus can be done by this chart, following this chart. If it is asymptomatic, no therapy is needed and pediatric examination is required. Periodically, it has to be checked. If it is symptomatic, then first of all, we need to look for candidiasis. If positive, then we will go for antifungals. If it is negative, if it is ruled out, then we need to see whether it is erosive or ulcerative lichen planus. Whether it is erosive or ulcerative. So if it is symptomatic, if lichen planus is symptomatic, then it will be erosive or ulcerative. Both are same meaning, erosive or ulcerative. So if they are erosive or ulcerative, we will go for topical steroids. If there is chronic ulcer, then we will use intralesional steroids. Steroids that are interlesional, steroids that are applied in the or on the lesion. So after topical steroids, if resolution occurs, that means if it is controlled, then we need to monitor. If it is not controlled, then we need to refer to a dermatologist or leave this. We need to go for other drugs like retinoids, dapsone, cyclosporine, photopheresis, systemic steroid. So basically, what are the management options or treatment or drug options we have? Drugs in lichen planus, number 1, topical steroids. Number 1 is topical steroids. Topical steroids including intralesional steroid. Intralesional steroids. Number 2, retinoids. Number 3, dapsone. Number 4, cyclosporine. Number 5, photopheresis. And number 6, systemic steroid. Okay, so 6 drugs. Total. Okay, next question. Band-like infiltrate of lymphocytes at the dermoepidermal junction and sawtooth rete ridges are diagnostic histological features of lichen planus, lupus erythematosus, psoriasis vulgaris, and seborrheic dermatitis. And the answer will be lichen planus again. So the characteristic features of lichen planus. These are pictures of lichen planus. So characteristic feature of lichen planus are hyperkeratosis, hypergranulosis, irregular acanthosis, presence of upper dermal band-like lymphohistiocyte infiltrate, and sheathette bodies. Presence of sheathette bodies. These are what? These are colloid bodies and hyaline bodies, also known as colloid bodies or hyaline bodies, representing basically they are keratinocyte which are degenerated and apoptotic. Which have degenerated and apoptotic keratinocytes. So basically sheathette bodies is dead keratinocytes or degenerated keratinocyte. Basically they are keratinocytes. Okay, so other features are hyperkeratosis with absence of parakeratosis, which is a mode of keratinization characterized by the retention of nuclei in the stratum of corneum. So hyperkeratosis with the absence of parakeratosis. So this is in this what happens, as we know that keratin, the nuclei will not be present when they will mature, but in this case nuclei of keratin cells will be present while they are in the stratum corneum layer, means most superficial layer. At that layer they should not have nuclei, but they will have in this case. Next is hypergranulosis, which is a thickening of granular layer with basal cell degeneration. Thickening of granular layer with basal cell degeneration. Basal cell means the deepest layer of the epidermis. Basal cell will be degenerated. So hypergranulosis, and the granular layer will be thickened. Okay, irregular acanthosis with sawtooth appearance of the rete sawtooth appearance of the rete ridges. Okay. Okay, and presence of upper dermal band-like lymphohistiocyte infiltrate. So this lymphohistiocyte infiltrate, these lymphohistiocyte infiltrate. It impinges on the epidermis, leading to obliteration of the dermoepidermal interface, and the presence of sheathette bodies. These are some characteristic features of lichen planus, and the gross uh, appearance of lichen planus will be like this. So different pictures you need to visualize different pictures, because they can simply give these lesions. Different not this picture, obviously other pictures of this lesion, and then they can ask most likely diagnosis. Question ends. Simple, this picture and most likely diagnosis. Maybe one line, something like, so a little bit of description of one line just. So picture is very important in dermatology. Okay, next question. Treatment of choice in this case: isotretinoin, tretinoin, benzoyl peroxide, azelaic acid. Now typical question, this type of question has come and in FMG recently, and is increasing little bit nowadays the frequency of this type of question. Just IBQ, just picture. So treatment of, first of all you need to understand what is the condition is, then you will think about the treatment. Okay, so treatment, first of all, what is this? This is cystic acne. Cystic acne. This is simply cystic acne. Acne, usual acne is this. Usual acne is there is pitting lesion. Lesions are pitting. There is pit. There is pit. But in cystic acne, in spite of instead of pitting, there is cystic appearance. These are cystic appearance. Okay, these are cystic appearance. So anyway, so cystic acne when you have when the patient have large red painful breakouts deep in your skin. It happens when this infection goes deep into your skin, when the acne infection goes deep into the skin, creating a bump that full of pus. So basically it starts with acne. It starts with acne. So it starts with acne, and then later it progressed to cystic acne. It progressed to cystic acne. All of a sudden, cystic acne will not come. Acne is basically it occurs due to hormones, and also, especially also, P. acne, Propionibacterium acne, due to this bacteria. Now, this infection, if it goes deeper into the skin, there will be formation of pus or pus accumulation, leading rise leading to or rise leading to rise of this cystic appearance. Cystic appearance. Cystic appearance that we call cystic acne, because there is pus inside. There is pus inside. That's why there there is cystic appearance. Okay. Anyway, so causes are menstrual cycle, pregnancy, menopause, PCOS, certain medications, some skin products, clothing that too tight, and high humidity or sweating. So all these causes are basically the causes of acne only. It's not different from acne. Acne on without treatment. Acne, if it is left without treatment, then it progressed to cystic acne actually. Okay, and treatment of choice is isotretinoin. We will revise the management of acne in little details. So first of all, when there will be mild acne, we will go for retinoids. We will go for retinoids. And topical retinoid. Then if there is papule and pustules formation, then we will go for topical retinoids. Topical retinoids means TR. So TR plus topical antimicrobials. TAM. Topical antimicrobials. Topical antimicrobials. Next, when there will be severity will increase, or if this doesn't give good result, then we will go for oral antibiotic or antimicrobials, oral AM, plus topical one, topical retinoid. Next, if it becomes nodular, then we go for oral antibiotic. We mainly stick to antibiotics and retinoids only, not BPO. Oral antibiotics, antimicrobials, plus topical retinoids. And at last, if it is nodular and conglobate, Then we go for oral isotretinoin. Isotretinoin. Okay. So this is the way we should increase the management. Retinoid, starting from retinoid, topical one, topical retinoids, then retinoids are always topical, so no need to tell retinoid topical. So retinoids plus retinoid, second stage retinoid plus antimicrobials, then oral antimicrobials with topical retinoids, then oral antimicrobials plus topical retinoids only. So these two stages will almost similar. Okay, moderate. These two stage, and then at last, if it is if it becomes severe, then we go for isotretinoin. So this table is very much crowded, and many things are complex, written in a complex way. Just remember, the first drug that we have is topical retinoids, then topical retinoids plus topical antimicrobials, then topical retinoids is fixed. So topical antimicrobials can be changed to oral antimicrobials. It will be more, it will be more systemic. And at last, isotretinoin. That's it. That's it. Just point number 1, point 2, point 3, point 4. Okay, next question. Target or iris lesion are seen in urticaria, erythema multiforme, scabies, lichen planus. And the answer will be erythema multiforme. So you need to remember this target lesion. You see, it's like the target lesion. This is called target lesion or iris lesion. Or iris lesion. Okay. Okay, next, so erythema multiforme. It is an acute, self-limited, usually mild, and relapsing mucocutaneous syndrome. Most common cause is infection with herpes simplex virus. So most common cause is herpes simplex virus, and second most common cause is mycoplasma pneumonia. Herpes simplex virus and mycoplasma pneumonia. Clinical presentation, it occurs in all ages, no age predispositions, mostly in adolescents, young adults, with slight male preponderance. So slightly males are quite more probable than female to get to get erythema multiforme. Characteristic target iris or bull's eye annular lesion. So remember all the name: target lesion, iris lesion. Same lesion is also known as bullseye lesion, annular lesion, because sometimes they cannot give the picture. They might not give the picture, but they will give the term. Bullseye is found in. So in this way also can come. So you need to remember the names. Most occur in the symmetrical acral distribution on the surface of extremities. Mostly occur in symmetrical acral distribution. So on the surface of extremities. Okay, so the site is very important. Acral distribution on surface of extremities. On surface of extremities. Okay, hand, feet, elbow, and knees. And also face, neck, and appear less frequently. Face, neck, and less frequently on thigh, buttocks, and trunk. Influenced by mechanical factors like Koebner's phenomenon and actinic factors like predilection of sun-exposed sites. Influenced by Koebner's phenomenon and those sites are also more probable to get erythema multiformis, where sun is solar light and solar heat is easily exposed. Okay, so this is about erythema multiforme. Next is annular herald patch is seen in lichen planus, psoriasis, pityriasis alba, pityriasis rosea, and the answer will be rosea. Rosea, pityriasis rosea is a common skin problem that causes a rash, multiple round to oval erythematous patches with fine central scales distributed pattern along with the skin tension lines of cleavage on the trunk is seen. Christmas tree pattern. Christmas tree pattern because these if you look at this, if you look at this lesion, Christmas tree is like this. Okay, so the lesion is like this. The pattern is like this. Christmas Christmas tree or fir tree pattern. Multiple round to oval erythematous patches. Multiple round to oval erythematous patches. Erythematous reddish. Erythematous patches with fine central scale. Classically begins with typical herald patch. This is called herald patch. So remember this term, very important, herald patch. Herald patch is seen in pityriasis rosea, P rosea. Typical herald patch and then becomes generalized patch. But starts with herald patch, then becomes generalized patch. Herald patch or mother's patch is also called mother's patch is first sign of pityriasis rosea. Fir tree or Christmas tree appearance due to distribution of lesion along the line of cleavage on trunk. Along the line of cleavage on trunk is seen. Okay, this is the very characteristic feature of P rosea, pityriasis rosea. Cigarette paper scales and involves trunk, spears, palm and soles. This feature differentiated from secondary syphilis, which commonly involves palms and soles. So anyway, so palms and soles are not affected in pityriasis rosea. Palms and soles are not affected. Okay. So next question. Pityriasis alba is a type of vitiligo, atopic eczema, photoallergy infection. Atopic eczema is the answer, and pityriasis alba is a variant of atopic eczema occurring in ethnic children. It's more noticeable in summer months. The loss of color is temporary and is not related to vitiligo. It's not related to vitiligo. So pityriasis alba is a variant of atopic eczema occurring in ethnic children and more noticeable in summer month. So P alba is a type of atopic eczema. Summer month, mostly in summer month. Loss of color is temporary and not related to it's not like vitiligo that is permanent. Okay, loss of color occurs but temporary loss of color, skin color. Actually, to be to be scientific, it's hypopigmentation. We don't say loss of color. Hypopigmentation occurs. Hypopigmentation. Temporary hypopigmentation is seen in pityriasis alba. Pityriasis alba. It should be preferably be treated with immunomodulators. Immunomodulators. Immunomodulators than steroid, but steroid is also functional here. Also, it can be steroid can also be given. Atopic dermatitis eczema is a condition that makes your skin red and itchy. is a condition that makes your skin red and itchy. So red skin, erythematous skin, and pruritic or itchy and itchy skin. No, pruritic. Common in children but can occur at any age. But more common in children. This is about pityriasis alba. Okay, next question. An adult patient presented with pruritic papules, pterygium of nails and oral involvement, most likely diagnosis. Most likely diagnosis is lichenoid eruption, lichen planus, lichen nitidus, and DLE. And the answer will be lichen planus. So in case of lichen planus, very easy to diagnose if you go by the clinical features. Always remember 6P. 6P. Number one, purple colored. Okay, purple colored. Number one. Number two, pruritic, means itchy skin. Number three, polygonal plain topped papules. So polygonal plain. Polygonal, what shaped? Polygonal. Number three, plain topped papules. 4, 5, 6, showing Wickham stria. Showing Wickham stria on peripheral parts of the body. Number 6, peripheral parts of the body, not central. Peripheral parts of the body, it can be elaborated as limbs, extremities, especially hands. Especially hands. Okay. So purple colored, pruritic, itchy, polygonal, plain topped papules, lichen planus papules, showing Wickham stria on peripheral parts of the body. Typical oral, typical oral involvement occurs in lichen planus. Okay, so here they have given pruritic papules, pterygium of nails, and nail pterygium also occurred. We have already studied that pterygium of nail is occurs in lichen planus, and oral involvement also occurs in lichen planus. Okay, so this is the thing. But out of 6P, if question comes for lichen planus question comes in FMG, you will get 2 to 3 P's will be written already in the question, like purple colored, pruritic papules are present. Okay, or maybe they will not elaborate papules as polygonal plain topped papules, but they will say papules pruritic purple colored on the hands. They will not completely use the PPPP. No, they may say on the hands or extremities. So you need to understand, okay, peripheral parts, that you need to understand. So they will not give straightforward, maybe a different way, but you need to understand. They may also use the word itchy instead of pruritic. Okay, only papules, not they may not have they may not use this polygonal plain topped papules. Okay, so in this way you need to comprehend the question and understand. Okay, next question, which is also known as sixth disease: measles, chickenpox, erythema infectiosum, roseola infantum. And the answer will be roseola infantum. Now, what is roseola infantum? It is known as exanthema subitum, meaning sudden rash. Sixth disease, that means sixth rash causing childhood disease. Now we will revise what are the rash causing, what are the rash causing childhood disease or pediatric diseases are there that causes rash, that cause rash. Okay, so sixth disease, because sixth rash causing childhood disease and 3-day fever, 3-day fever, that is baby measles. It is caused by two human herpes virus 6 and 7, human herpes virus 6 and 7. Okay, in short, first is rubella, second is scarlet fever, third is rubella, fourth is fillet of Duke's disease, least asked. This is least asked. Least asked in FMG. This is not so much asked. Fifth disease and sixth disease, mostly this is asked. Fifth disease and sixth disease, erythema infectiosum and roseola. So viral infections of the skin and eyes. Viral infection of the skin and eyes, we will see fifth disease. This is the so these are the first, second. Each one of these they can directly ask fifth disease is erythema infectiosum. So you need to, this is the fifth one. So you need to remember each one of these. Fourth is not so important. Okay, no, fourth is not so important. Now we will go through some viral infections of skin and eyes. Fifth disease is roseola infantum. Roseola infantum. Roseola infantum. Caused by parvovirus B19. Slapped cheek rash. Very important this term. It comes in FMG. Slap cheek rash. In fact, the picture is also important. And transmission is highly contagious via respiratory secretions of infected individuals. Next, herpes keratitis, HSV1, inflammation of conjunctiva and cornea, irritation, excess tear, sensitivity to light, lesions in cornea leading to blindness. Direct eye contact with discharge from herpes lesion elsewhere in the body or from another infected individuals. Acyclovir, ganciclovir, famiclovir, valacyclovir. These are the antivirals that we can use in herpes keratitis. Oral herpes caused by HSV1 may cause initial systemic symptoms, cold sores, highly contagious via direct contact with infected individuals. And the drugs, antiviral drugs include acyclovir, penciclovir, famiclovir, valacyclovir. Papillomas caused by HPV or human papillomavirus, common warts, plantar warts, flat warts, filiform warts, and others. And contact with infected individuals, and topical salicylic acid can be used for papillomas. And roseola infantum, exanthem sibutum, roseola infantum. Oh, this is fifth. Oh, I'm sorry. This is erythema infectiosum. This, not roseola. This is the fifth disease. Erythema infectiosum. Okay, fifth disease. That is erythema infectiosum is caused by parvovirus B19. Okay, parvovirus B19. This, and this is the sixth one. This is the sixth one. And slapstick rash, contagious of via respiratory secretion of infected individuals. Slapstick rash occurs in erythema infectiosum or fifth disease. And in sixth disease, It is HHV, HHV6 and HHV7. Human herpes virus 6 and 7 is the causal organism, causative organism. And cold-like symptoms with high fever followed by macular or papular rash 3 to 5 days later, and spread by viral and respiratory secretion of infected individuals. Ganciclovir can be given or immunocompromised. For immunocompromised patient, ganciclovir can be given. And viral conjunctivitis. Viral conjunctivitis. In viral conjunctivitis, adenovirus is the causative agent, and the inflammation of the conjunctiva, watery non-purulent discharge occurs. Common cold is associated with common cold, contagious via contact with eye discharge. With eye discharge. Okay, so these are the viral infections of skin and eyes. Okay. Okay. Next question. Okay. Next question is slapped cheek sign is seen in parvovirus B19, JC virus, rotavirus. It will be rotavirus, and chickenpox virus. Rotavirus. So answer will be, we just have studied parvovirus B19 and erythema infectiosum. So fifth disease, right? This is the fifth disease, and the IBQ, for IBQ, image based question. For IBQ, this picture is very important. Is also referred to as fifth disease or slapped cheek syndrome or slapped face. The name fifth disease is derived from its historical classification as fifth of the classical childhood skin rashes caused by previously called parvovirus B19. Smallest single DNA virus, smallest single stranded ssDNA virus. Okay, parvovirus B19. And this fifth disease or erythema infectiosum is a mild infection caused by a virus. Mild infection caused by a virus spread through respiratory droplets. So spread through respiratory droplets. Such as when an infected person coughs or sneezes. It can spread through blood transfusion. Erythema infectiosum is most common in school-aged children. Flu-like symptoms appear, and followed by face rash, then a body rash also. And the rash may stay up to 10 days. So headache or the body aches, fever, chills, tiredness, stuffy nose, runny nose, sore throat, flu-like, all these flu-like symptoms. In one word, flu-like symptoms. Nausea and diarrhea, bright red, warm cheek rash. This typical rash you see, like someone has slapped on his face. Okay, that's why slapped cheek syndrome. Slapped cheek. Okay, red itchy body rash that has less pattern, and joint pain, swelling also occurs. Treatment is antihistamines for allergic reactions, and ibuprofen or acetaminophen for flu-like symptoms like headaches, body aches, fever, chills. Ibuprofen can be effective for that. Okay, or acetaminophen can be given alternatively. Okay, so this is about erythema infectiosum. Next, measline. We have already studied this in the today. That measlines on nail involvement, under nail involvement. Measlines on nail is seen in lichen planus, psoriasis, arsenic poisoning, hypoalbuminemia. So the answers will be arsenic poisoning. Out of these options, the correct answer is arsenic poisoning. But measline also found in Arsenic poisoning, yeah, only here also it's written arsenic poisoning. Okay, so iron deficiency anemia, koilonychia, arsenic poisoning, misline, lichen planus, pterygium of nail, onychia, pitting of nail, and in psoriasis, pitting of nail. So pitting of nail, pitting, again we revise, nail pitting is found in, lichen planus, and in psoriasis. Okay, so nail pitting. And Quelonychia is spoon shaped nail, and shaped nail. Okay, spoon shaped nail, and arsenic poisoning in misline is found. So now our question is, misline on nail is seen in arsenic poisoning, appear after the episodes of poisoning with arsenic, thallium, or other heavy metals. Basically, heavy metals, heavy metals poisoning gives misline. Okay, especially with arsenic and thallium. So heavy metals can also appear if the subject is suffering from renal failure. Misline is also found in renal failure. So you can understand one thing, that in several conditions misline is found, but out of the options do matter. If it is options like thallium, poisoning, arsenic poisoning, renal failure, all of these, So misline on nail is seen in arsenic poisoning, thallium poisoning, arsenic poisoning, renal failure, all of these. And the answer will be all of these. But this set of options that are given here in the question, lichen planus, psoriasis, arsenic poisoning, and hypoalbuminemia. So the answer will be arsenic poisoning. Okay. And also they have been observed in chemotherapy patients. Number D, chemotherapy patients. Okay, so this is heavy metals. Poisoning. So thallium, arsenic, especially heavy metals poisoning, renal failure, chemotherapy patients. In all of this, misline is found, and the misline is typically this. Otherwise, this. You see this. Otherwise, the nail is fine. So if this picture is given and you try to find out the nail, if someone doesn't know the misline, the nail will seem to be all fine. Okay, but misline, you need to know where the misline is, then you will understand, yeah, misline is there. And so this is the case of misline. They can also do, they may, if in FMG may not be, this term may not be there. So this nail, the condition of the nail, this condition of this of the nail is seen in, the question will be the condition given in the picture, the condition of the nail given in the picture is seen in which one of these following. So you need to understand the picture also for IBQ purpose. Okay, for IBQ type of question, you need to find understand the picture also. Okay, next question. An 80-year-old child has itchy rash all of the body, all the family members are having the same problem. Okay, which drug is preferred? Topical permethrin, fluconazole, steroid, and antibiotics. The answer will be topical permethrin. And what is the condition? That is the important. This is scabies. Itchy rash all over the body. Itchy rash all over the body, and all the family members, very common, All the family members have the same problem. In scabies, do remember there is very few conditions like this. In scabies, whole family is given treatment. Whole family is given treatment. Okay, and the scabies side is 5% permethrin, topical permethrin, should be applied nicely. In fact, for students, roommates, or for family members, whole family, with whoever the patient stays, the whole whoever stays, those person also have to do the same treatment. Okay, there will be and it is caused by mite, burrowing mite, Sarcoptes scabiei. An intense is itching occurs in the area where the mite makes burrows, and it is very much contagious and can spread quickly through close physical contact in the family. So whole family is advised to take drugs, and scabies can be readily treated by applying medications. And the signs and symptoms are itching, severe, usually worse at night. Thin and irregular borous tracts can be seen, made up of tiny blisters or bumps on your skins. The burrows or the tracts typically appear in the folds of the skin. Folds of the skin, almost any part of the body may be involved. In adult and older children, scabies is most oftenly found. So, almost in all genders, almost in all ages, and all the mm, all over the body, and the treatment should be given to the all the members of the of a family. Okay, so do remember scabies, scabies, this all this this all theory, this all, remember all, what, many alls are there. Okay, so all the folds, first of all over the body, all over the body, all the members should be treated at once, members of family members. Okay, then all the folds of the skin can be involved, all ages, almost all ages, especially in adult and uh, especially in children and adult. Especially in adults and older children, scabies is mostly found, but almost all the ages can be affected. Then all over the body worsen, and okay, so this all over the ages. So the remember these points, okay, and treatment is very good. Treatment, with treatment it can be cured very nicely. With the prognosis is good, scabicide 5% topical permethrin, permethrin should be given. Okay, and that's it about scabies. Okay, next question. A 10-year-old boy, sorry, a 10-year-old child presented with recurrent painful mouth ulcer. Okay, recurrent painful recurrent painful mouth ulcers. On examination, they were found as yellowish elevated spots surrounded by red halo. Yellowish elevated spot surrounded by red halo. Okay, tend to heal within 7 to 10 days. History and findings are consistent with the diagnosis of, and the answer will be aphthous ulcer. Aphthous stomatitis. Termed as recurrent aphthous stomatitis, is a common condition characterized by repeated formation of benign and non-contagious mouth ulcer. Non-contagious, not contagious. Okay, non-contagious in mouth ulcer, and these ulcers occur periodically, occur periodically and heal completely between attacks. In periodically, but in between two events, it will heal completely. In the majority of cases, the individual ulcer lasts about 7 to 10 days, and episodes occur 3 to 6 times per year. So actually, quite often, almost 2 months, 3 months gap. Okay, this is aphthous ulcer. Okay, Barlock dermatitis is because of, okay, animals, plants, household stuff, cosmetic, and the answer will be plants. Plants. Its Barlock dermatitis is actually called as phytophotodermatitis. Phyto means plant, photo means light, dermatitis, inflammation of skin. So for phytophotodermatitis, it's also called Lyme disease, Lyme. Very important. Do not confuse it. Do not confuse it with Lyme, Lyme disease, not Lyme, Lyme disease. Okay. This is also called phytophotodermatitis. Is also called Barlock dermatitis, which is basically it's a chemical reaction. Chemical dermatitis is dermatitis due to chemicals that are found in plants, in simple words. Okay, so chemical reaction that makes skin hypersensitive to UV rays. That's why phyto, because it started all from the chemicals from plants, chemicals that are found in plants. They start, and photo, it leads to photosensitivity, increase photosensitive to UV rays, UV light. That's why phytophoto. Frequently mistaken for hereditary conditions such as atopic dermatitis or chemical burns, but it is caused by contact with photosensitizing compounds found naturally in some plants and vegetables like citrus fruit, especially that we handle and use quite often in our daily lives. Okay, basically these plant chemicals or citrus chemicals in citrus fruit plant, these plant chemicals, what they do, they increase the hypersensitivity or make or sensitivity, hypersensitive, hypersensitive, it makes our skin hypersensitive to UV light. So it makes our skin hypersensitive to UV light, and that is why what happens, these patches you can see, this dermatitis you can see is due to the sun rays. That's why you see the exposed area, mostly the exposed area, like this we wear clothes, so the exposed area, mostly the exposed area will get dermatitis. Dermatitis, sun exposed area, sun exposed area will get dermatitis. These are most common symptoms of phytophotodermatitis: inflammatory eruptions on the skin, blisters and burning sensation, skin aspect typical to one of the sunburn. It looks like sunburns. Actually, sunburns occurs also due to ultraviolet, and type 4 hypersensitivity reaction to UV rays. So next, the skin can present red and erythematous and itchy patches. Eruption heals. If eruption heals, it can turn brown. Basically, these eruptions that are shown in the picture, they are brownish color. They have healed, but they become like this. Okay, in brownish color. Otherwise, first it will be erythematous, red colored itchy patches. and when it heals, it becomes brown. The skin becomes discolored, lasting for months. As the eruption appears only on the skin, as the eruption appears only on the skin areas where the toxins have reacted when exposed to UV light, unusual patterns can appear on the skin. That's why there is no fixed pattern. So because the pattern of this lesion depends on the how much the came into chemicals has came into contact, how much the how much of the skin, how much of the skin got exposure to sun, how much skin, which area of the skin got exposure to sun. So it depends. That's why the shape is not fixed. The shape of the lesion varies. Okay, so this is phytophotodermatitis or Burlock dermatitis. Okay, as for the treatments, we can reduce the inflammation. We can reduce the inflammation by topical and oral treatments. Bleaching creams. Bleaching creams can be used, are indicated for the areas of skin where hyperpigmentation has produced. Maintenance of proper hygiene. Hand must be washed after handling citrus food. Now, after handling citrus food, if that hand we give in the neck or wherever we will touch, those chemicals will be transported. Yeah, and then when sun exposure will be, we will get sun exposure. The person will get sun exposure. This type of reaction, dermatitis will occur. Okay, otherwise we use fruit with hand, but we will use that hand, touch that hand without washing the hand. We will touch that hand in other places. So from that only the chemicals from the plants or citrus fruits will reach those places. Okay, so next, avoid the plant or plant products from which it is initiating. Even plant that can cause this, if they are burnt, then the smoke from that plant can come in contact with the skin to cause dermatitis as well. Okay, so wet cold compress can reduce the inflammation, soothe the skin. Anti-inflammatory medications like steroids can be given. So the main theme of treatment is reduction inflammation reduction. And and another thing very important, proper hygiene, means washing the hand, and avoiding the fruit or plant plant product, avoiding this agent. Okay, agent. So this is very important. In fact, there is no surety that there is not only the raw fruit or raw plant can occur. That is not the point. In fact, the final product of some like factory made products or some uh, factory made products of food, packed food products, okay, or dry foods can also occur, because dry or packed foods can contain the plant products or the plant products or the extracts of the plants. Okay, so that's why they also can cause the same thing. They also can cause Barlock dermatitis. Okay, so avoiding the agent including citrus fruits, plant products, plants, raw plants, or any plant finished products. Okay, and proper hygiene, washing of hand, and inflammation reduction by topical steroids, topical steroids, and also oral treatments. Oral steroids can be given. Then bleaching creams can be given. All these things. Okay. So next question: a 6-month-old baby presented with skin rashes with scaling on face and antecubital and popliteal fossa. Okay. Most likely diagnosis: contact dermatitis, allergic, atopic eczema. So the answer will be atopic dermatitis. Now, what happens is that atopic dermatitis is associated with allergy to house dust, mite allergens, food intolerance, food allergy. And in acute phase of childhood atopic dermatitis, facial skin may be erythematous with scaling. Which is our question actually. Skin rash with scaling on face. Flexures of elbow, flexures of elbows and knees, cervical region, wrist, ankles are characteristically involved. So the sites, very important sites. Cardinal feature, character, characteristic feature of atopic dermatitis is pruritus, itchy, and scratching account for most of the signs. And family history of atopic dermatitis triad. Family history, dermatitis, asthma, allergic rhinitis. This is a family. This is a triad of atopic dermatitis. Another thing is Hannifin and Rajka diagnostic criteria are used for diagnosing atopic dermatitis. And this is the list of clinical features of atopic dermatitis. Lots of features of atopic dermatitis are there: lichenification, P. alba, ichthyosis, keratosis pilaris, hyperlinear palms, cheilitis, then atopic, then Denley Morgan folds, Hartog's sign spin, that means thinning of lateral half of the eyebrows, hyperpigmentation of lower eyelids, firm rubbing of the skin elicits white dermographism, white dermographism with no erythema. Okay, no erythema, but only dermographism. It looks like it's a dry skin. It looks like dry skin, but it's a severe dry skin. It will be severe. It will be severe. You can literally draw, literally write something like if you write A B C D. If you can literally write on the skin with some little bit sharp object, not sharp or blunt object. We can say not sharp like knife, like nails. Okay, nails. Okay, and it can be diagnosed by Hannifin and Rajka diagnostic criteria. Hannifin and Rajka diagnostic criteria is this: at least 3 major and 3 minor criteria must be fulfilled out of this list. So go through this list. Like 3 major: pruritus is very important, early age of onset, typical morphology and distributions, chronic and chronically relapsing dermatitis, and personal history or family history of atopy. Atopy. Atopy means allergic. Atopy means allergic, eosinophilic. Okay, IgE mediated reactions. All are IgE mediated reactions: asthma, allergic rhinoconjunctivitis, atopic dermatitis. All these are IgE mediated allergic. History of allergy runs in the family. Okay, and minor criteria is increased serum IgE level, immediate type 1 skin response, susceptibility to cutaneous infections, white dermographism, nipple eczema, epidermis alba, hand foot dermatitis, xerosis. Treatments very important: emollients for dry skin, corticosteroids, ointments, tacrolimus. 50% in 50% cases, disease remits spontaneously between 2 to 5 years. In adults, it's milder. Systemic therapy: oral prednisone as antihistaminics, antihistamines, anti-staphylococcal antibiotic also, phototherapy, and in this is recalcitrant cases. That means resistant cases. If the above drugs doesn't work, then go for cyclosporine or mufetil or azathioprine. Okay, resistant cases. Okay, a young child of 4 years old. Young child of 4 years old had blisters which ruptured to form crust. Okay, that are honey colored. Little bit golden. Okay, it golden yellowish, yellow golden. It appeared around the mouth as shown in the picture. Okay, which one of the following statement is false? This is due to streptococcal infection. Blisters were thick-walled. Lymphoadenopathy is common. Blisters occurs more on the face. Okay, this is due to streptococcal infection. Blisters were thick-walled. Lymphadenopathy is common. Blisters occurs more on the face. So the answer will be blisters were thick-walled. This is false. It should be thin-walled because there were blisters. In this case, first of all, this condition is typically impetigo. You need to understand the condition first, and to be specific, in impetigo contagiosa. In this, what happens? Blisters occurs, but they are thin-walled, and that is why they easily ruptures. They easily ruptures, forming crust of honey color or honey colored crust. So impetigo can be of two types. One is bullous impetigo, one is another is non-bullous impetigo. So in non-bullous impetigo, it is also called impetigo contagiosa. It occurs due to group A beta hemolytic streptococci, more commonly Staphylococcus aureus. Okay, it occurs in preschool young children. Blisters, thin-walled blisters occurs on erythematous base. So blisters, thin-walled blisters, and base is erythematous, red colored base. Erythematous base, thin-walled blisters. Ruptured rapidly to leave honey-colored crust, lesions spread without central clearing. That means where it first starts, then it spread. But the site where initially it got or it appeared, those lesions stay there, doesn't leave those place. Okay, doesn't resolve, and frequently there will be lymphadenopathy. Then site is face, around mouth and nose. Here also in the picture, around mouth. Complications can be post-streptococcal glomerulonephritis, kidney involvement, ecthyma, scarlet fever, erysipelas, cellulitis, lymphangitis, bacterial endocarditis. So all these are complications of impetigo contagiosa. Next, bullous impetigo, coagulase positive group 2 Staphylococcus aureus. Most Staphylococcus aureus. Okay, mostly neonates and infants are involved. And here thick-walled blisters occurs. So thick-walled blisters occurs in bullous impetigo. But they talked about this. This question belongs to impetigo contagiosa or non-bullous one. And persistent blisters occurs because these are thick-walled. Persistent blisters occur on blunt skin. Rupture only after a few days to leave varnish like crust, not honey-colored crust. So they told rupture to form in the question. They told rupture to form honey colored crust. So when it is honey colored crust rupturing and then honey colored crust is appearing, that means bullous, sorry, impetigo contagiosa, non-bullous impetigo, non-bullous impetigo. So blisters has to be thin walled, not thick, not thick but thin walled. If it is if it is written rupture to form crust, varnish like crust, then it can be thick walled. Another thing is that the age, young child of 4 years, bullous impetigo most commonly occurs in neonates. Neonates first 28 days and infants. Neonates and infants, not in preschool or young children. Young children, bullous, no, bullous impetigo in neonates and infants, non-bullous or impetigo contagiosa occurs in young children. Okay. So lesions heal in center. Here, see, in bullous, in impetigo contagiosa, central clearing, there is no central clearing, but central clearing is present in bullous impetigo. Lesions heal in center to form annular plaque. So again, another thing can annular plaque is seen in bullous impetigo and not in impetigo contagiosa. Another very important is sight. Face is the only side, especially around mouth and nose, is the only side of impetigo contagiosa, while face and other parts of the bodies are involved. Other parts of the bodies are also involved in bullous impetigo. Complications can include in bullous impetigo SSSS, Staphylococcus scaldes skin syndrome, SSSS, pemphigus neonatorum, cellulitis, lymphangitis, pneumonitis, septic arthritis, osteomyelitis, and septicemia. All these are complications of bullous impetigo. Okay. Now the treatments. Treatments includes mupirocin 2% cream, fusidic acid 2% ointments, amoxicillin, clavulanate, amoxicillin, clavulanate, augmentin. It's called augmentin also. Okay, both combination. It can be given cephalexin and clindamycin. So these are the treatments of impetigo, whether especially for non-bullous impetigo. Okay, impetigo contagiosa. Okay, next question. A patient of 51 years old sorry, 51 years old has unilateral vesicular eruptions. Okay, unilateral, very important this point, unilateral vesicular eruptions in the root and side of the nose with severe pain. So you haven't got this type of question, unilateral vesicular eruption, in any other slides. Unilateral, this point is very important, unilateral. So which virus involves skin according to the dermatome or neural distribution? Because then why unilateral only? What is if it doesn't go according to the dermatome, then it would be generalized. But in the picture you see, it has not gone to the right side, only the left side. Very strictly, its left side is affected. Left side of the patient is affected. Even the eyes, So anyway, we will go to the answer. Answer is herpes zoster. First of all, varicella zoster primary infections occur. Primary infection occurs and it remains in latent stage. Then it reactivates and it causes reactivation causes herpes zoster infection. Herpes zoster infections in the posterior root ganglion of spinal nerve. And if patient without immunity to chickenpox contacts, then it may develop chickenpox also. Mostly affected those after, means post 50 years of age. And HIV infected persons are 20 times more likely to develop herpes zoster. Very common for HIV positive patients. Unilateral vesicular eruptions within a dermatome. Within a dermatome associated with severe pain, thoracic dermatomes are most commonly involved. Thoracic one. And herpes zoster ophthalmicus, Hutchinson signs is positive. Ophthalmicus, eye involvement occurs. Lesion on the tip of nose, root and side of the nose and inner corner of eye. Indicates ophthalmic branch of the trigeminal nerve. In this picture also, ophthalmic branch of trigeminal nerve is affected. This is basically the case of HZO, herpes zoster ophthalmicus. It's a marker for stroke in ensuing year also. Stroke can occur in the following year. But for this picture, we must understand that this is Hutchinson's sign, lesions on the tip of the nose, nose tip of the nose, root, root and side, root of the nose and side of the nose, root of the nose, side of the nose. Okay, root and side of the nose and inner corner of eye. Inner corner of eye. This is inner corner of eye. Inner corner of eye. It indicates ophthalmic branch of trigeminal nerve involvement. Herpes zoster oticus or Ramsay-Hunt syndrome. In this, pain and vesicles appear in external auditory canal. And loss of taste sensation occurs in the anterior 2/3 of the tongue while developing ipsilateral facial palsy. So in Ramsay-Hunt syndrome, ipsilateral facial palsy occurs and geniculate ganglion of the sensory branch of the facial nerve is also involved. Treatment will be acyclovir, famciclovir, valacyclovir, or for herpes zoster. And vaccine is there, live vaccinated vaccine. And vaccine should be offered to persons 60 years and older, but cannot be used in children. Okay. Okay. So this is about herpes zoster. Okay. Next question. A male patient of 23 A male patient of 23 years old presented with itchy silvery scale. Itchy silvery scales on the elbows as shown in the picture. So very easy actually. Answer will be psoriasis. Now etiology is associated with HLA-CW6 positive family history in more than 50% patients. It affects 1 to 2% of the world's populations. Most common abnormalities increased epidermal proliferation rate. We have done this in the previous class. The turnover time increases. Turnover time decreases. Mitotic activity in psoriasis increases. What happens? Mitotic activity increases. That's why turnover time decreases. And it averages 4 days only. One MCQ was there. No. So the most common abnormalities increase epidermal proliferation rate. And in histologically, we see parakeratosis. Stratum corneum contains nuclei again, as we have done already in this class also. Acanthosis. Munro's microabscess can be seen. Collection of neutrophils. Munro's microabscess. This is typical histological picture of acanthosis. Munro's microabscess. This, remember this, each of these picture. Munro's microabscess is seen in, then acanthosis is seen in, granular layer is absent, hyperkeratosis with parakeratosis. is found in psoriasis. Collection of neutrophils in the stratum spinosum. Then migration of neutrophils out of dilated dermal capillaries, suprapapillary thinning with the thin epidermis above edematous dermal papillae, exaggeration of dermal rete pattern. Okay, an absent granular layer occurs. So these are the histological features of psoriasis. Okay, some of the aggravating factors of psoriasis includes pregnancy, sepsis, stress, cold injury or winter, streptococcal infections, trauma, drugs like beta blockers, lithium, mood stabilizer, lithium, antimalarials, chloroquine, NSAID, ibuprofen, sudden stoppage of systemic steroids can aggravate psoriasis. That's why systemic steroids are given as a course, and the patient is advised, highly advised, strictly advised to complete the course, not to take according to his or her wish, or stop it, yeah, according to the wish, patient's wish. Otherwise, sudden stoppage can lead to condition like this, psoriasis. Clinically, chronic inflammation of the skin disorder characterized by erythematous, sharply demarcated papules and round plaques covered by silvery mica-like scales. Most common age of onset is second and third decade. Common sites are extensor aspect of elbows, extensor aspect of elbows, knees, scalp and sacral areas of nails. Skin lesions of psoriasis are variably pruritic. Stable plaque psoriasis, psoriasis vulgaris. Most common type of psoriasis is stable plaque psoriasis. Common sites are extensor aspect of elbows and knees. So the one that given in the question is stable plaque psoriasis. This is, if we categorize it, stable plaque psoriasis. Okay, next, gutted or raindrop psoriasis or gutted eruptive psoriasis, more common in children and adolescents, frequently preceded by streptococcal sore throat infection. Anti-streptococcal antibiotics may be necessary. Self-resolving quite rapidly, tonsillectomy has been tried. Okay, self-resolving self-resolving type, this gutted psoriasis also responds rapidly to UVB type. So as for the treatment of gutted type, we can give UVB. Erythrodermic psoriasis include features like skin becomes universally red, erythematous. All over the skin will be erythematous skin, scaly skin. More than 90% of the body gets involved. Erythrodermic. Shivering compensates for the considerable heat loss. As there is heat loss, shivering starts. Erythroderma initiated by irritant effect of tar or dithranol or by systemic or topical steroids withdrawal. MTX or methotrexate is the DOC. Others are cyclosporine. Seborrheic psoriasis includes classical lesions on scalp. In seborrheic psoriasis, classical lesions on scalp is associated with typical moist lesion in body folds like groins, axilla, submammary regions. No visible scales are found and can be very resistant to therapy. Pustular psoriasis, it's rare. So rare form of psoriasis is pustular one.